people are there who are suffering from something, but they don't seek the help because of the social issues.
Yeah, that is every society has it. Every society has it.
हमें उनमें विश्वास जागृत करना होगा, उनको बताना होगा कि हम आपकी हेल्प करना चाहते हैं, उनको एक्स्ट्रा टाइम देना होगा सर, जितना
Still
हम
someone listen. What to do?
एक्स्ट्रा टाइम, जैसे अगर हम फीवर के लिए आ रहे हैं 5 मिनट में देके और दवाई लिख के और दे देते हैं, इनमें काउंसलिंग बहुत जरूरी है सर, बहुत ज्यादा
training area.
Good afternoon, all the seniors.
Flight vannitte evada thamam.
Good afternoon, Dr. Nile.
Okay. Paul Russell.
Hello.
Good evening, sir. Good evening.
Okay.
Good evening. क्या हाल चाल?
बहुत अच्छे सर.
Oh, I got
2 मिनट बाकी हैं, 32 बंदे हैं अभी.
Yes. आ जाएंगे सर सब लोग.
वो सब आ जाते हैं टाइम. अभी कितने सेशन बचे अपने?
आज 4 टोटल 9 सेशंस हैं सर, 5 और रहेंगे.
I am supposed to do one more, I think. Is it?
Yes, sir.
When is it
Yes.
supposed to be?
I need to check the date, sir.
And you better inform me in advance and the topic also, because I'll get committed.
Sir, आपको तो emergency base में भी बुला लेंगे तब भी हो जाएगा सर आपसे.
नहीं, but I won't be available now. I may be busy with something else.
नहीं सर, मैं 1 मिनट बताती हूँ सर. Just let me once.
I know there is one more. I want.
Yeah, there is one more, sir.
So, role of parents, sir. Parental counseling.
Parental counseling. Okay.
Yes, sir. Role of parental counseling, and it is on 15th September.
15th September. Okay.
Along with Dr. Hima Bindu ma'am.
That means there's a lot of time.
Yes. Hima Bindu madam will be taking pre-marital counseling on the same day, and you will be taking the role of parental counseling.
She has become a young girl again, doing premarital counseling and all. Hima is there? No. She is not here in this group.
नहीं, ग्रुप में है मैडम, आज आएंगी. यूएस में आज.
अच्छा.
यूएस में है.
Okay.
ज्वाइन करेंगी, वो कह रही थी मैं करूंगी ज्वाइन.
Yeah, all my topic, a lot of people have taken. What can sexuality has taken by who? Our tutors, sir. Premarital counseling taken by her. What do I find now? I have to find new topics.
Good evening, Madhushri ma'am.
Good evening.
Good evening.
Welcome, welcome.
Good evening, MKC sir. Preeti
Good
ma'am.
evening. Good evening. Good evening.
Good evening.
Am I
ma'am. Good
audible?
evening.
Because
Good
there's
evening,
some.
beta. Kaise?
Yeah, you are audible.
Because inside the NICU, there's no proper network. That's why.
You are audible and you are looking beautiful also.
I wanted to say, but nowadays I don't say like that.
So I took the advantage of saying
Now,
sir.
when you came for training, I must have told her this. Amrita, did I say that?
You didn't say.
You didn't say?
No, sir.
No.
Good evening.
Nowadays, I'm trying to become a little more reserved.
Good evening, ma'am. Good evening. Welcome.
Good
Thank
evening,
you
ma'am.
for coming, ma'am.
Preeti madam, Amitha, Shubhada, all I think back.
Good evening, madam. Good evening.
Even Geeta Patil, I must have said, you're looking beautiful.
Oh, thank you, sir.
Patil ma'am is always beautiful. Shilpa, we can start now.
Good evening, everyone. Shall we start? It's 4 o'clock sharp.
Yeah, you can start.
Yeah.
Started. Okay. So, a very good evening to the esteemed members and colleagues. I, Dr. Shilpa Bhargava, Secretary CGAHA, on behalf of CGAHA, feel honored to welcome you all to the 4th session of our e-webinar series on adolescent counseling in office practice, basics and beyond. The series is organized by CGAHA Very well designed, advised and proposed by Dr. M.K.C. Nair, sir, Dr. Preeti Galagali, ma'am, and Dr. Kavita Menghani, ma'am, under the guidance and supervision of Central IAP and Central AHA. This series has been a resounding success. Today, we address a critical issue that is becoming increasingly prevalent in our clinics: anxiety and depression among teenagers. As pediatricians, we are often the first point of contact for these young individuals, and it is essential for us to be well equipped to handle these cases effectively. To begin, let us extend a hearty and warm welcome to our guest of honor, Dr. Prakash Veer Arya, sir, Secretary, Central AHA. We feel privileged to have sir with us for the session. We extend a gracious welcome to our honored guests and participants, Honorable National President, Central IAP 2024, Dr. G.V. Basavaraja sir and his effectual team, respected Geeta Patil ma'am, Chairperson, Central AHA 2024, and her enterprising team. We are delighted to welcome Dr. Ashok Mehta sir, Executive Board Member, Central IAP 2024, distinguished Dr. Kiran Makija sir, President, CGAP 2024, and his zestful team. It's my honor to welcome distinguished assembly of guests, which includes Dr. M.K.C. Nair sir, Dr. Preeti Galagali ma'am, Dr. Ashok Makija sir, Dr. Sangeeta Joshi ma'am, Padma Shri Dr. A.T. Dabke sir, Dr. A.P. Sawant sir, Dr. Sunita Kothari ma'am, Dr. Amar Singh Thakur sir, Dr. Madhushri Deshpande ma'am, Dr. Ashok Sundarai sir, and so many esteemed members. We are honored and privileged to welcome our chairperson for today's session, Dr. Nilay Mojarkar sir, Treasurer, CGAP. We are pleased to welcome esteemed speakers of the day, Dr. Amitha Rao ma'am, Adolescent Health Specialist. She will be taking case-based counseling, depression, and Dr. Shubhada Khirwadkar ma'am. She is also an adolescent health specialist and will take case-based counseling anxiety session. To commence today's session, I would like to invite Dr. Prakash Veer Arya sir, our guest of honor, to offer his insight and words of wisdom with the gathering.
Thank you. Thank you, Shilpa madam, for inviting me in this seminar. First of all, I welcome to all esteemed dignitaries of Central IAP and AHA in today's meeting. I salute the zeal and attitude of the esteemed academicians doing great work for our own adolescent. I welcome Dr. M.K.C. Nair sir, Dr. Preeti madam, Dr. Geeta Patil madam, Dr. Ashok Makija sir, and Madhushri madam, and other esteemed guests present in this meeting. I best wishes to Chhattisgarh AHA, especially Dr. Kavita, Dr. Shilpa, and Dr. Avinash for today's marvelous work for our adolescents. Chhattisgarh is one of the vibrant branch of AHA and doing CME continuously on various topics of clinical importance. Today's topics, case-based counseling, depression, and anxiety, were very important, and with good history taking, we can pick up such type of problems, and early diagnosis and treatment is the golden rule in this management. Now, I am sure that today's speaker, Dr. Amitha Rao madam and Shubhada madam, will do justice with the topic and explain nicely about and enrich our knowledge over these topics. Over to Dr. Shilpa madam.
Thank you, sir. Thank you. Thank you for your nice words, sir.
Thank you, sir, for your kind words. And now it's my pleasure to introduce our respectable chairperson for the session, Dr. Nilay Mojarkar sir. He is Treasurer, Chhattisgarh IAP 2024, past President of Raipur Academy of Pediatrics. He is in charge Pediatric Unit in District Hospital Raipur, Master Trainers for various government trainings like NRP, speakers at various IAP and non-IAP platform, and he is a known personality and an eminent speaker and a renowned pediatrician at Raipur. And we are cherished to have you, sir, for the session. I would like to request and appreciate if Dr. Nilay sir could share his thoughts with us and offer some remark, as well as introduce our first guest speaker, Dr. Amitha Rao, ma'am.
Very good afternoon to all of you. I think previous two people have taken so many names, so I take the privilege and I namaskar all of you together.
Thank you.
Okay. And I am very delighted to see the galaxy of academicians in the program. So I think it will be a good discussion, will be a good presentation and followed by a good discussion also. So adolescent, the topic is, I think I'm not very much versed with this adolescent topics. So let's hear the speakers first, and then we can, give some thoughts or something like that. So let me introduce our first speaker, Dr. Amitha Rao Arur, ma'am. She is MD, PGDAP, and she is Professor of Pediatrics and Adolescent Health Specialist in AJ Institute of Medical Science, Mangalore, Karnataka. And she is faculty at Adolocon and National Pedicon conferences, various conferences. And there are 25 publications in national and international journals. And she is the author of the chapter in UG textbooks and adolescent modules. And she has conducted several parenting and school health programs. So I invite Dr. Amitha ma'am for the presentation.
Thank you, sir. Thank you, Chhattisgarh AHA, Dr. MKC, sir, Dr. Preeti, ma'am, Dr. Shilpa, and Dr. Kavita for this opportunity. I'll be talking on how we can approach an adolescent client with depression. Is my slide visible?
Not yet. Not yet.
Okay, 1 minute.
No, ma'am. It's
Yeah,
not visible.
Yeah. Now make it full screen.
Yes,
Yeah, perfect. Good.
Thank you, sir. So depression is a common condition which affects adolescents that we all are aware. And why is it important to screen? If we screen early and detect early, treat early, they have a better outcome. On the other hand, if we miss this opportunity to screen, diagnose, and treat, it can lead to various serious consequences. Now, how do we screen for depression in adolescents? There are several self-report questionnaires. The simplest one is PHQ-2, which has 2 questions. One, depressed mood. Second one is decreased interest in pleasurable activities. Each is scored from 0 to 3 based on the frequency of symptoms. So if the total score is more than 3, it is taken as positive. Further modification of this, which is recommended by American Academy of Pediatrics for screening adolescents, is PHQ-9, which has 9 questions. And these questions are same as those used in the diagnostic criteria in DSM-5. Another valid and reliable tool is the Beck Depression Inventory. Now, what we need to remember is whichever screening tool we use, if we get a positive screen, we need to go ahead with the detailed evaluation before we make a diagnosis of depression. Similarly, if we get a negative screen, but still we strongly suspect depression based on the clinical symptoms, even then we need to do a detailed evaluation. Now, the diagnostic criteria used for depression is same as that is used in adults. The duration of symptoms should be at least for 2 weeks. One of the 2 primary symptoms, that is depressed mood or loss of interest in pleasurable activities, and at least 4 of these 7 additional symptoms. The point to note here is, unlike in adults who usually present with low mood, depressed adolescents sometimes may just present with irritability. So hence, irritability also has been included as one of the primary symptoms. Now just let's see a case. Meghna, who is 16 years, studying in 10th standard, has presented with feeling low since 6 months. She has withdrawn from her family and friends, and she has school refusal since 2 weeks. On screening, she is diagnosed to have moderate depression. Now, how do we go ahead with this patient? So whenever we see such a case, we need to look for two things. One, is there any organic cause which can cause these symptoms? For example, anemia, hypothyroidism can have symptoms of depression. Autoimmune diseases can have CNS involvement with depression as one of the manifestations. Second thing to note is it a unipolar depression which we can assess, treat, and refer when required, or is it a part of some psychiatric disorder where we must refer to a psychiatrist? So once we rule out organic diseases and make sure that she's suffering from unipolar depression, the next step is to do a detailed HEADS assessment. Now, the HEADS assessment in Meghna has certain red flags. That is, she has scored low in her test, which is held 2 weeks back. She used to love badminton, but she has stopped playing since last 3 months because she feels tired most of the time. And she reports sad mood on most of the days with the score of around 3 on the scale of 1 to 10. If we note the strengths, she is above average in studies. She has a close bond with her mother, and she used to love badminton. Let's see how we can interview this adolescent. Here we assume that we have established the therapeutic relationship, we have explained the confidentiality, we have done the HEADS assessment, and we are directly getting into her presenting symptom of low mood. Okay, Meghna, you said you're feeling low these days, right? Since how long this has been? Is it audible? I just want to confirm the video.
Yes, ma'am. Yes, it's audible.
Yes,
It's audible better, but one thing you have to say, this is not a patient. We are just doing a demonstration.
I was planning to say that at the end, sir.
No, you should say it in the beginning.
Okay.
Not fair.
Yeah, it's not a real life scenario. She is my very efficient postgraduate, Dr. Meghna, who has played the role of the patient. Okay, Meghna, you said you're feeling low these days, right? Since how long this has been going on? Can you elaborate on that?
It's been going on for some time now. I feel sad and lonely these days. I won't feel like doing anything or talking to anybody. Recently, in my social exam also, I scored very bad marks. I don't know why. I just want to sit at home and do nothing. I hate feeling this way.
I understand. It might have been really difficult for you to come here as well.
Yes, but I would like for it to get better.
Yeah, that's great. I appreciate your decision to seek help. And it's a big step in the right direction. May I know what you're expecting from the therapy?
I would want to go back to how it was before. I want to score well in exam. I want to go back to talking to my friends and family. I want it to get better.
Okay, I understand. You're feeling sad, lonely. You want your life to be like how it was before. You're worried about your exam and you want to improve on that. Maybe that is something we can keep it as a goal. Is that okay?
Yes, but is it really possible?
Definitely. I am sure with therapy you will definitely improve and you'll feel much better. I understand being in 10th standard, you might be very busy with your studies. And during the therapy, I might give you some homework exercises and you might have to come for around 10 to 12 sessions. Is that fine with you?
Yes.
So the points to note here are, the counselor asks open-ended questions to explain her symptoms, empathizes with the client throughout the interview, appreciates client's decision to seek help, summarizes patient's issues, and gives a ray of hope to the patient when the patient feels that there's nothing much which can be done. Now, if we see, most of the time when the patients present, they present with vague or non-specific symptoms. For example, here she has presented with low mood, school refusal, etc. So to see what exactly goes in their mind at that point of time, it is better if we can discuss a specific situation. Now, let's see how the interview continues. Meghna, you said you're getting some thoughts which are disturbing you, right? All of us do get certain thoughts sometimes. And what we are doing in the therapy is trying to identify some of these thoughts and see what that leads to. Okay? So can we discuss about a specific situation? Can you tell me the recent time, which has really something that has really upset you?
Like I told you, my social exam, I studied well, but I did it horribly. I don't know what happened only. Like, I feel terrible. Like I studied well and I couldn't do well. It was like
I understand. Now, let's break it down. Meghna, you said you felt low. You felt very bad when your social exam score was low. So, what exactly ran through your mind at that point?
even if I study, I won't be able to get good scores. Even if I do well, it won't get better. It'll be the same.
Okay. In that case, how does that make you feel?
Like nobody would want to know me. My friends wouldn't want to talk to me. Nobody would want to spend time with me.
Okay, great. And how does that make you feel?
Like I am worthless person. Like I am a failure.
Understand what you're going through. So if I get it right, you're feeling that you're a failure, you're worthless, and probably the recent low score in your exam has reinforced this, right? Am I right? So you said you did try to get over it. What exactly did you do?
I did everything, like anything I could, I did. I tried everything. But at the end, it felt like sitting at home and doing nothing, not talking to anybody, and just being at home would make it feel better.
I understand it might have been really tough on you. And did that help sitting at home and not interacting with your friends? Did you feel better with that?
No, I actually felt still worse, still horrible. It was a terrible feeling.
So here, if we see, she has mentioned in the recent time, the low score in the exam has upset her. So by interviewing or asking questions regarding what she felt at that point and questioning on those thoughts, we try to find out what is her core belief. Core belief is the belief which we have about ourselves. So she had a core belief that she is a failure and she is worthless. The low score in the exam has precipitated various thoughts in her, like she can never succeed. Nobody will like her if she doesn't do well in the exam. Nobody wants to spend time with her if she doesn't succeed. So all these thoughts, if we see, they have words like never, nobody, must, always, etc. So these thoughts are called the negative automatic thoughts. So because of these thoughts, Meghna has felt sad, lonely, extremely worried, which has led to her various behaviors like avoiding people, withdrawal from family and friends, and school refusal. Now, in depression, usually patients have certain cognitive distortions. If we see in Meghna, one failure in the exam, she thought she'll never do well in her life. So that is overgeneralization. She kept on thinking about her negatives and just ignored the positives. That is mental filtering. Once she has failed in the exam, she thought in future exams also, even if she studies, she'll not do well. So that is overestimating the possibility of bad things happening. That is probability overestimation. Emotional reasoning, that is because she felt she is worthless, she accepted it as a fact. And lastly, she felt her friends will not like her, that is mind reading. So these are few of the cognitive distortions which Meghna had. There are many more which I have not mentioned in the slide. Now, once we identify by interviewing, asking a specific situation, what is her thought, what was the core belief, then next step is to challenge the automatic thought and the core belief. So we need to ask the client or the patient to write down from their past experience, what are the points or evidences that favored their belief and what are the evidences that were against. Now, when Meghna was asked to do this exercise, she had 2-3 points which were favoring her thought, but there were many more which did not support her belief. Like she said, she regularly scored well in the school. Teachers always told her she's an above average student. She was able to do well in studies even when she was attending the badminton classes. And her friends always said that they liked talking to her. So this exercise made her think what she was thinking. Was it true or was it just her belief? So she was willing to test it in reality. So we motivated her to go back to school, interact with her friends, where she realized that her teachers and friends were happy to have her back. They interacted with her just like how they were interacting before. So this made her realize that her academic performance has nothing to do with people liking to talk to her. So this way, in every session, we try to identify some of the cognitive distortions, some of the negative thoughts, try to challenge them and change into realistic ones. This is usually coupled with behavioral activation. Behavioral activation is encouraging the pleasurable activities. For example, here she used to like badminton classes before which she stopped. So she was told to restart her badminton classes, interact more with her friends, talk more to her mother. So all these make them feel good. Now, usually for the therapy, they are called on weekly basis. They usually require around 10 to 12 sessions. So in between the sessions, we need to advise them few things. That is one, the relaxation exercises. Second, behavioral activation. Third, to keep a mood diary. So mood diary is the exercise that we tell them to do at home. That is, they write down the trigger that precipitates certain emotion. What is the emotion felt? What is the intensity? For example, if they feel sad, is it around 80%, 90% like that? What was the thought they had in their mind at that point? What were the points favoring their thought, against their thought? What could have been the alternate thoughts and the new emotion that would have developed because of this alternate thought? So initially, the patients might find it difficult to do this, where in the subsequent session, the counselor can help, but subsequently, they will be able to write down what might be the alternate thoughts with which they have healthier emotions. Now, this is what we call as cognitive behavioral therapy. So that is, it is based on the fact that how we think about a situation decides on how we feel about it and how we act on it. So CBT basically addresses the cycle at two levels, at the thought level and at the behavior level. So what do we do at the thought level? At the thought level, we identify the negative automatic thoughts and try to change into realistic one so that they have healthy emotions and positive behavior. What do we do at the behavioral level? We advise behavioral activation exercises so that in general, their mood is good and they get more of positive thoughts. The CBT has been found to be very useful in mild and moderate depression and also in in severe depression when combined with drug therapy. Now, whenever we approach such a patient, we need to look for 5 Ps for assessment as well as for therapy purpose. First, what are the presenting symptoms? Here it was more of mood related, emotion related, and behavior related. What are the risk factors that is predisposing this adolescent to have depression, be it genetic or environmental? Here, if we see, it was attachment of her self-worth to academic performance. What is the immediate precipitating factor which is causing these emotions in her? In her, it was low score in the exam. What are the factors or perpetuating factors that is maintaining this state of low mood or the depressed mood going on for a longer period of time? In Meghna, it was rumination, guilt, withdrawal. And lastly, what are the protective factors which the therapist can act upon? CBT is the most commonly used form of therapy. The other therapies which are useful are interpersonal therapy, which basically concentrates on strengthening the interpersonal relationships, the ACT therapy, and dialectical therapy for especially those with extreme emotions, suicidal ideation, etc. Pharmacotherapy is indicated in severe depression and also in moderate depression when the patient is not responding to psychotherapy. There are 2 drugs which are FDA approved for adolescent depression, that is fluoxetine for more than 8 years, escitalopram for more than 12 years. Both are SSRIs. Both need to be started on a lower dose, gradually increase on weekly basis to attain the therapeutic response. There are minor side effects, which is usually well tolerated as we continue the therapy, but we need to warn the parents regarding 2 things when we start the therapy. First, when we initiate the therapy, especially in the first 2 to 4 weeks, there can be increase in the suicidal ideation. So we need to advise the parents, especially in the first month of therapy, or when we increase the dose, they need to keep a close watch on the child. Secondly, it's a common tendency that when the child feels better, they stop the medication. We need to tell them the treatment has to be continued for at least 6 months after attaining remission, the total duration of around 9 to 12 months. And if the treatment is stopped early, there can be relapse. there are certain indications where we must give psychiatry referral. That is when it's recurrent or persistent depression, when the patient is not responding to therapy, when there is severe functional impairment, those with suicidal and homicidal behavior, and when we feel that this depression is a part of another psychiatric disorder. So I would like to conclude saying that as pediatrician, we are the first point of contact for the adolescents. So we need to have a high index of suspicion, screen for depression, diagnose, treat, and refer whenever required so that they have a better quality of life. I would also like to thank my postgraduate, Dr. Meghna, for participating in the role play. Thank you.
Thank you, Amitha ma'am. It was such a nice, easy, flowing presentation so that everybody could understand what exactly you wanted to say. Second best part was the video of that counseling, the gestures, the way of the counseling, the empathy was, was there in the acting, I think, and especially when the patient was saying her core belief that she is worthless, and the madam has put her hand on the patient's hand. That was the I think very good part.
She's my postgraduate who has played the role of the patient. She's Dr.
Yes,
Meghna.
ma'am. Yes. So I think that was very wonderful. It was an easy way to teach everybody how can we counsel the patient. Not only adolescent, even each and every parent and patient, we should counsel like this only. So can I go with the questions?
No, Nila, Dr. Nila, it's second session then.
Okay.
Yeah.
Okay.
You take questions at the last of the session.
Okay, so let's start the second session, which is on anxiety. So the speaker is Dr. Shubhada Khirwadkar, ma'am. She is MD and she's MA in clinical psychology also. And she is the EB member of Adolescent Health Academy in 2021. She was the past president of Adolescent Health Academy and IAP Nagpur. She is director of Tender Buds Child and Adolescent Care in Nagpur. And also she is director in Saman Sehat projects of tribal children in Melghat. And she is working as a pediatrician in Mahan Trust Tribal Hospital. She is the national scientific, she is the she has several books and publications. She has written books, newspaper columns, articles, TV, and given the presentation on TV and radio programs for understanding adolescent child care and parenting. And she got the award for the best work award for the Adolescent Health Adolocon Khajuraho 2017. And she is also having 16 national awards as a president IIP Nagpur and 4 gold medals. And she is honors in pediatrics. So she has more than 100 workshops on parenting, more than 200 workshops on adolescent life skills. And she is a teacher training workshop on nurturing adolescent. And also she is faculty for IAP action plan module like MKU and MSU. So I welcome Dr. Shubhada ma'am.
Thank you so much. It was a longish introduction, but thank you for your kind words. At the outset, let me salute our patron, Dr. MKC, Preeti Madam, Geeta, my co-faculty, Amitha, Prakashvir Arya Sir, and all the esteemed members of AHA, Central as well as Chhattisgarh AHA. It's always a pleasure to be with all of you and an honor to understand so many things from you is really wonderful. As I had already said in the beginning, it's difficult for me to share the screen. So I would request Kavita to please share it.
Sure, ma'am, sure. Nilay, can you share it from there?
I'm trying, but it's
No,
not.
Dr. Nilay,
ma'am.
Dr. Nilay.
मैम मेरे पास ना पहला वाला था, ये वाला नहीं आया है।
एक सेकंड मैं इधर से ट्राई करती हूँ। निलय मैं आपको भेजती हूँ ना, मेरे को इस तरफ से वो हो रहा है। जस्ट सेंडिंग यू। हाँ just 1 second. नीला सेंट यू है ना, एक बार देखो आप।
Is it visible? I am also trying.
No.
No, ma'am, it's not visible. Just 1 second. Dr. Nilay is trying, ma'am. He will do. Don't worry.
Okay.
I think by the time we can take a couple of questions. Amitha, are you there?
Yes, ma'am. Can take by the time.
Yeah. Amitha?
Ma'am, yes, ma'am.
Yeah, so there's a question on confidentiality. The first question, when do we break confidentiality?
Yeah. Whenever we talk to the adolescent, we need to tell them that whatever they say will be confidential between the therapist and the adolescent, unless there is some instances where we find that that is risky to the adolescent's life. Then safeguarding the health of the adolescent becomes a priority. So for example, suicidal ideation, homicidal ideation. So such instances, we need to take the adolescent's permission and reveal to one of the parents or the trustworthy adult, whomever the adolescent is willing to.
Yes. Thank you, Amitha. And in addition, child sexual abuse cases have to be mandatory reported to the police. And also when we need to hospitalize the adolescent, there's a surgical procedure and in all medical legal cases. So thank you, Amitha. I think Shubhada slides are visible. Yeah, Shubhada, over to you. Thank you.
Thank you, Dr. Nilay. Please go to the next slide. Yeah. So we have this case vignette of Ankita, 16-year-old girl, brought by her parents on the advice of the school teacher. She had 3 episodes of fainting in her class in past 2 months, twice during term examination and once on the eve of her maths paper. The episodes were associated with giddiness, blackouts, tremors of hands and feet, and palpitations, sweating, and a feeling of extreme weakness. However, she was awake, alert, and was not unconscious during the episode. She was made to lie down, her necktie loosened, a few drops of water sprinkled on the face. These first aid measures terminated the episodes, and she was absolutely fine at home on the days in between. Next one, please. So there was no history of nausea, vomiting, absent attacks, or any involuntary body movements, uprolling of eyeballs to rule out epileptic or such other abnormal voluntary movements, no loss of consciousness. She did not have specific avoidance symptoms, obsessive thoughts, or repetitive behavior, no history of seizure disorder, specific phobias, or separation anxiety disorder in childhood, and no such complaints in the family. Next one, please. So my plan when I had Ankita in my OPD was to get some information from the school, because the episodes happened in school, from the parents, take a detailed medical history, do physical examination, if required lab investigation, and then if there is no other organic cause, then counseling with psychosocial history and the SCARET tool, because I had an inkling that she may be suffering from a disorder related to anxiety. Next one, please. So after detailed physical examination, nothing abnormal was found. No anemia, no signs of a thyroid disorder, blood pressure was normal. There were no skin signs of pheochromocytoma because these symptoms might mimic an adrenal medullary tumor. Neurological examination and fundoscopy was normal. Next, please. Her CBC showed 12g% hemoglobin, though a mild hypochromia was there. The thyroid function tests were all within normal limits. Ultrasonography for any adrenal or any other tumor which had manifestation of autonomic disorder were ruled out. Next one, please. So on section 1, after ruling out any other cause for her episode, the basics was to build a rapport with a brief introduction and greetings with her parents and smiling welcome to Ankita. Information about the fainting was asked on the phone from the teacher and actually from the parents when they were in my OPD. And the parents were then politely asked to wait outside with Ankita herself expressing her desire to talk alone. Confidentiality, as just now explained, the rules were expressed and the conditions for break were also summarized. And I began with an open-ended question: how can I help you, Ankita? My gestures like forward bending, head nodding, congenial tone, smiling demeanor, eye contact were all used in engaging her in the general beginning talk. Right. Next slide, please. So she was initially hesitant, which is always the case with any adolescent, but then she talked about her irritability, restlessness, being on the edge as her examinations approached. She was often unable to sleep, concentrate on her studies, and was worried about recalling the studied portion. She sometimes went blank while solving the paper, but was able to solve the same sums when she was back home or in the coaching class. So she also gave exams in the coaching class, but there she had no issues. She could easily give the paper. After this first session, she was scheduled by her parents and teachers, and they on their own again took her to the examination hall to give the examination. But she was struck by another fainting attack, and it was followed by tiring easily and frequent headaches. Next one, please. So in the next session, in the same session, I did head assess. Nuclear family, highly qualified parents, both doctors, had big expectations from Ankita. Her average score till ninth it was low, but always low, and she had failed in maths twice. Her activity showed that she was good at table tennis, music, but she had 6 hours of school and 4 hours of tuition. She had few friends. She liked to be alone, but she was not a loner. Used to watch late night music videos, and there was no specific study or sleep schedule. She was an avid devotee of Krishna. No psychotropic drugs, sleeping pills were taken, occasional junk food. Next one, please. Non-gear two-wheeler, she used to drive with a helmet. Sexuality, she had steady relationship with son of a family friend, but there was no sexual intimacy and no thoughts of or attempts of self-harm. Next one, please. So on Ankita's CARET test, the general score was 30, and on panic disorder, the score was 8. Next one, please. So when we decide or when we think about anxiety, DSM-5 classifies it into 5 disorders: generalized anxiety disorder, obsessive compulsive, panic disorder, phobias, and a social anxiety disorder. Now, Ankita, no, the previous one, please. Ankita had symptoms of generalized anxiety, but it was not overreaching to affect other spheres in her life. She had some fear of examination, so maybe she was suffering from phobia about the examination. Obsessive compulsive disorder was ruled out because she had no intrusive or obsessive thoughts or repetitive behavior. Social anxiety disorder also was ruled out because she did not have any specific anxiety of social situations. But she had autonomic symptoms. She had palpitations, sweating, blackouts, especially when she entered the examination hall, especially during the school examinations and not during the coaching class examination. She had these typical attacks of panic and she used to avoid examinations. So with a high score on panic disorder, the provisional diagnosis of panic disorder was 10. Next. So her issues, her faulty cognitions, finding out the short-term and long-term goals of therapy, what could be the facilitators or the barriers, and how to terminate the therapy was the entire plan. Next one, please. So when we deal with any case of anxiety, often these symptoms overlap each other. So there might be some symptoms of even depression overlapping because it's a spectrum. And therefore, we have to have specific issues in mind so that what we need to do is to plan according to what we have to do at a short term and what is our final goal. And accordingly, we have to keep on getting feedback and have an eclectic approach and a flexible approach depending upon the response of the patient. Next, please. Next, please. Sorry. So Ankita's extreme worry of failure to do well in school examination was her core thought, which needed restructuring. She felt she was an undeserving daughter of academically successful parents, with a special emphasis on the word undeserving. She had shame and guilt for respecting the family name because she thought she should never fail. Math failure put a stamp of failure on her entire personality. Approaching 10th board was a huge academic burden, and instead of learning ways to handle anxiety, she was trying to avoid the situations which can lead to extreme anxiety. Next one, please. So the plan was to start with the relaxation technique. Progressive relaxation technique, all of you know, that was taught to her in the OPD, and then her parents were asked to videograph it so that the correct technique is seen by the practitioner. Then certain meditation techniques, visual imagery were also thought of. Drugs which can be used to reduce the somatic symptoms of anxiety so that she becomes amenable and receptive to counseling. That this is often found, and this is my experience, that initially if anti-anxiety drugs are given, then the patient settles down, calms down, and becomes more amenable and approachable for counseling. For her panic events, she needed some type of systematic desensitization. And on a immediate basis, she needed to have certain study skills, time management, better solving techniques in math with one-to-one coaching. And an important beginning we have to make is to reassure the parents that the drugs and the skills both help and equip to handle anxiety. Taking teachers on board, especially if we have to do this desensitization in school, is very important because their sensitive and empathetic approach would help us in the actual desensitization. Next one. So in the next session, discussion on plan of action, preference and hierarchy, which things need to be done in the beginning, which later. Ankita herself expressed that she would like to learn the fear handling technique. After reassurance to the parents, 20-gram fluoxetine was started once a day, and a sleep and relaxation routine was started with parents' help. Next one. Then next, counseling sessions on cognitive restructuring, either CBT or REBT. I used CBT sessions here and planned it for every week for next 10 days, and the counseling sessions for reaching the short-term goals. Sorry. Sorry. Please excuse me for my bad throat. So alternate day counseling sessions were planned for the short-term goals, and for the long-term restructuring or the change in the cognition and the behavior thereof, 10 sessions were planned weekly. Fortunately, the parents were very responsive and they agreed to the plan. For systematic desensitization, we need to have permission from the school, which was taken. And often we face these adherence issues and irregularity of the scheduled sessions, as was pointed out by Meghna in the beginning. So that's a big challenge for the counselor. And often the school assignment deadlines also come in the way, and the adolescent is not very regular in the session. So that did happen with few sessions. But overall, it was a very systematically approached by the parents as well as the teacher. Next one, please. So these were the few things which were practiced in session 4, 5, 6. Progressive relaxation, deep breathing, meditation. She was a Krishna devotee, so chanting was also employed. Mindfulness meditation. She was also made to understand what were the cues for the panic attack and how she can use them to relax, and the various techniques she can employ with these cues so that the attack doesn't happen. Also, the importance of learning study skills as well as life skills was emphasized. Next one, please. So, in the study skill sessions 7 and 8, SQ3R, which is a very well-known technique, was used. In addition, memory cards, topic mapping, focus reads. I have a counselor in my assistant counselor in my OPD who gives all these sessions to the adolescents for their improving their study skills. Also, general guidelines and management of sleep, diet, exercise, and time were employed. Next one, please. Because she had those episodes of long watching in the night music videos and may have had some digital well-being issues, these were the points which were also told. These are separately discussed in probably a session on how to wean a child from digital addictions. Next one, please. So with the parents, 2 sessions were planned in between to take their feedback, the adherence, any difficulties they are facing. Accordingly, alternative strategies were planned, and they were encouraged to start her music and table tennis, on which she was having a very good command. Next one, please. Teachers were taken on board at every step, stepwise confronted. This is systematic desensitization, which we did in the school, using the corridor, then the door, then inside the hall, increasing the time. With every this intervention, she was asked to recall in terms of visual imagery as well as deep breathing, relaxation, and finally the self-talk that she is getting better, not only feeling better, but getting better. And that created a lot of impact. And finally, she could give her exam after 10 sessions of short term, after 3 weeks. Next one, please. The sessions on cognitive restructuring, as we have enumerated the faulty cognitions, on every cognition, she was questioned, then rationalizing her cognitive thoughts, arguing with those thoughts, how she can prove that the thought is not the realistic one. All these were done. So critical creative thinking skills were also taught to her as part of life skills. And as is very common, some sessions were missed, but overall improvement in anxiety level noted by all the 3, Ankita, her teacher, as well as her parents. Fluoxetine was not required to increase, only 20 milligram was continued. It was continued over the next 2 weeks, and after 8 months of CBT, with no reporting of panic attacks, termination of the therapy was done. Next one, please. Thank you.
Thank you, ma'am, for a wonderful presentation. And I think we have all learned how to tackle the depression in adolescent and anxiety in adolescent. And the message which I got is that there could be a mixed bag of symptoms, and every patient is separate, and the plan should be according to the patient. Whatever symptoms the patient is having, the plan should be according to those symptoms, whether it is mixed or single. And parents, involvement of parents in their teaching and their counseling is a must. So let's go with the questions. I think first question was already discussed. Now, there is one question here is, without compromising confidentiality, to what extent we can inform the school and friends?
Amitha? Is Amitha there?
Yes, ma'am.
Yeah, Amitha, can you take that question?
Should I repeat? Should I repeat?
Yeah.
Yes, sir, please repeat the question.
Without compromising confidentiality, to what extent we can inform the school and friends?
This is regarding depression.
Yes, yes.
You're asking regarding informing either school, friends, or parents. If we find that there is risk to adolescent life, we have to inform one of the parents or the adult. If we need assistance from the school, where there might be some adjustment from the adjustments, either timing or extra time for homework, etc., from the adolescent, maybe parents can talk to the teacher or the counselor can talk to the teacher after taking permission from the adolescent.
What is dialectical therapy?
Sorry, Nilay, I'll just come in here. We have a separate
Okay.
session on dialectical therapy.
Yeah.
Okay,
So
fine.
please
So
we'll park that question. We'll take the
Sure,
other
sure.
questions first. Yeah, yeah. We have a
Did
full
you
session.
rule out any physical health issues? I think this has been
Yes.
already
By
done.
history, examination
yes,
and
yes.
investigation,
Yes,
CBC
yes.
basically to see
Yes,
the
yes.
hemoglobin, TFT.
If the adolescent manages well on the low dose, do we still need to escalate the dose? I think this has already been discussed.
Yeah.
And can I just come in again, Nilay? We have a separate
Sure.
session on pharmacotherapy. So
Sure,
we'll
sure.
all the questions regarding drugs, we will take it with Dr. Paul Russell. So please
Okay.
park your questions for pharmacotherapy with Dr. Paul Russell. Let's just focus on counseling. Yeah.
DBT is a type of CBT which will help to manage intense emotions and handle the stress. I think this is a comment. What is the end point of drug treatment? I think this has also been discussed, and I think it will discuss later on in other presentations. What is the difference between RE that was presented last time in CBT that was spoken now?
In REBT, you challenge the irrational thought. Here, you are not challenging. You are making the patient realize that what they are thinking, is it really a fact or is it their belief? So you're not going to challenge. The patient himself or herself realizes that it is probably not rational, and then they change into realistic ones.
And in REBT, it is basically rationalizing the emotions depending upon the change in thoughts, right? And a lot of homework is given. That is a separate kind of therapy where you have to go as A, B, C, D, E, antecedent for the behavior and all those things we have to find out. So it is a very structured therapy with a lot of homework for the client to do.
Okay, ma'am. So this is, does one need special training for doing CBT?
Yes, boss.
Yes, yes,
Yes.
yes.
Okay. It is generally said that relaxation technique and meditation put a depressed person to more depression. Instead, they should be engaged in activities that keep them active. I think this is a question. Could you please speak on this? So
No,
it is
the
generally said, I will repeat it.
No, I understood the question. The activities which bring them happiness, like they have mentioned, jogging, walking, etc., that basically increases the endorphin and keeps them happy. Relaxation is for a different purpose. It is for relaxing your body and mind, for calming the mind, and definitely it doesn't add on to the depression. It's two different purposes.
Yes. Once on antidepressants, always on medicine. I think this already discussed and we'll discuss in next presentation. How long antidepressants should be continued, when to stop? This is again the same thing. Also for substance abuse also. This is comment, I guess. Even recreational drugs, no need to inform its violation of privacy. But how to balance? Is this a valid question? Even recreational drugs, question mark? No need to inform its violation of privacy, but how to balance?
I think, Nilesh, somebody has asked about substance use and whether it's an indication for breaking confidentiality. So, Amitha, Shubhada, do you want to just come in? Is substance use an indication for breaking confidentiality?
I think substance, I'm not very sure, ma'am. If I'm wrong, you can correct. If substance use is in the early stages, just like once or twice experimenting, and if the adolescent has understood the risks and promised not to do it again, we need not reveal to the parents. But if they have gone to a stage like withdrawal or addicted, then definitely we need to take the permission and involve the adolescent parents for the therapy. That's what I feel. You can correct, ma'am, if I'm wrong.
Shubhada, please unmute. Please unmute, Shubhada.
I feel with the use of these substances is illegal in India, so we need to inform the parents.
With or without permission of adolescent?
With permission of the adolescent.
So there is the, Shubhada, there's the act which comes in, the NCTBS Act it tells about, you know, the amount of substance which should be there to really kind of report it, you know. So if they're just coming with a mild or a moderate substance use disorder, and if you're not putting them on any medication, because the moment you put them on medication, you have to take the permission of the legal guardian or the parents, or if they require admission, or it's a severe substance use disorder with multiple comorbidities, with suicidal ideation, and there, you know, you need to involve the psychiatrist, you need to refer, definitely parents have to be involved. But if somebody just says, I had a cigarette once, and otherwise you have done a good screening, you may not reveal, but you have to keep a very close watch, sometimes even calling up that patient again and again to make sure that the patient is okay. So I think this is a little tricky, but yes, that is what, I mean, according to the current
But
thing.
if the patient is using some kind of illicit, cigarette is just injurious to health, right? So it is not an illegal way of taking drugs. But if there is some drug, say, I had a recent case where, which is a drug, some name for marijuana, which is illegal in India. So if the child said that I went to that hookah place and took marijuana twice with my friends, so what do I do? Should I inform the parents or not?
See, Shubhada, you may have to partner with the adolescent here, see the triggers for taking marijuana there, and say to keep yourself safe, you know. Again, you will have to take it case-wise. We cannot have a blanket kind of a thing. It also depends whether this child had a learning disability, this child has depression, this child has anxiety. So, you know, usually they will go to drugs. Usually if there's, sir wants to say, yes, sir. Yes, sir.
Yeah, I think two philosophy you should keep in mind. The first one is the best interest of the child. By telling the parent is going to create havoc in the house, more problem in the school, more problem there. I think we are making a mistake by telling unnecessarily. On the other extreme, there are few things which legally you are bound to tell. They are 100%. The other places use your judgment. If the parent is supportive and child will get it, the best interest of the child, because you are not bothered about the whole world, you are only bothered about the child who is presenting in front of you. So that would be the answer. You cannot give correct answer for this 1 cigarette, 2 cigarette, 1 drug, 1. You can't say like that. That is your judgment. But if it is legally bound to say it, then we have no choice. We have to do it. Okay.
Okay, sir. Next question, I think it is, when the patient is visiting in the OPD for vaccination or other health issues, and you find that there's some mental health issues, so how successful are we in eliciting open answers in the first session itself?
Not very successful. Not always successful.
So again, I will say it depends upon, you know, what kind of rapport you have with that patient. So, you know, maybe you've known that patient since he was a small baby, right? And if we can get into the habit of speaking alone to our patients once they cross 10 years, and just take a very short, brief heads. How are things at home, school, online with friends? You can kind of get a lot of answers. But I do, in a very busy OPD, you may not be able to deal with all those. So it's best to kind of do a quick screen and tell them and give them an appointment to come later. So I can say it is really, you can be extremely successful, or you may have a 0 success or something in between. So again, it depends on your rapport. Yes.
Okay, ma'am. So similar kind of question. Is it important
I'll
to
just
ask?
add one thing.
Sure.
First time when you were riding a bicycle, it was so difficult. But after riding for many months and years, it comes so naturally. Counseling or asking these children is like that. As a newcomer, you find it very difficult. Bottlenecks are so many. But if you have the habit of, doing that 1 or 2 questions only, but to find out if there's a problem, after some time, you can do it so easily. Only thing somebody asks a question in between. Every child, it is important to ask a mental health question. It is important, but not the whole one series of questionnaire. Ask 1 or 2 questions which may be leading. That should be enough. Okay.
Sir, can I ask one question, sir? This teen screen questionnaire for the mental health and physical health is really very useful to be added in our routine when they come for the health card also.
I didn't say it because it happened to be mine. I have
Yes,
done
sir, Trivandrum, sir.
1.5 lakh.
Because, that is very useful.
I don't
found
use
out-
anything else. But I didn't say because it's mine and I kept quiet.
No,
because
sir, it is very useful. Everybody should know that. Please, teen screening questionnaire for mental health. And maybe if you want to add in your health card also, that helps a lot. And it screens very easily. For every adolescent also, we can ask.
It
Not
takes,
only they
it
come
takes
for
maybe 2-3 minutes. All you have to ask is 3 questions first. That is, you have a problem, 3 things. Then in the end, you have 3 questions on your helplessness, your worthlessness, and talk about, your 3 things, 1 more. So that's all what is required. Anyway,
Hopelessness.
leave it.
Yes.
Hopeless also.
Hopelessness.
So next is, what is systematic desensitization?
Right. So systematic desensitization is an exposure therapy. So that person, the client is afraid of something, like our Amitha was afraid of going into the examination hall and giving her exam. So this kind of fear, if it is for a situation which is not exactly harmful for the child, but for the adolescent, but the adolescent thinks that avoiding is better than handling that anxiety. So you expose the adolescent stepwise. Like I told about taking her to the corridor and then going back, having a chaperone in the examination hall for some time, then sitting there for some time, giving herself deep breathing techniques to relax, self-talking that she is okay, she is going to do it, like that. So you keep on exposing for a longer period so that the fear of that situation slowly withers away. So that is called as systematic desensitization.
Okay, ma'am. And the other questions are on drugs, I guess. So that should be taken care of later on. Yes. And the last one is teen screening questionnaire for mental health. Can you please share on group?
Yeah. We do have
Yes, we'll request sir to share it with us and we put it on the group.
Okay.
Yes.
Okay. So this closes the question answer session. So
any comments
this,
by Dr. Nair? MKC
yes.
sir?
Sir.
I would like to make 1 or 3 comments. Number 1, remember that all children, adolescents who are depressed may not appear depressed. They will come and hey, and all that, they will come to you and you get taken away by their behavior. But if, especially girls, when they do all this, you just watch their eyes for some time, then say, better, good, all this is great. Then why are you crying inside? Why are you suffering so much? Just ask one single question. Suddenly she will start crying and the whole lot of things open up. So remember that, don't get carried away by the external behavior. Adults, it may not be so. Adolescent, number 1. Number 2, do not forget other comorbidities with the depression. I have a child who is 5 years actually was on drugs. Somebody asked, how long can you give? I didn't give the drug. Paul Russell gave Velo. She was on regular visit. She had to be given on 5 years. And in between, when he was not there, somebody started risperidone. So because a psychiatrist started, I didn't want to stop it, but I was not comfortable with it. So when Paul came back, I asked him this question. He said, let me have a look at the chart. And he said, yes, very well, it is written there. What the child having is OCD. She has all sort of thoughts. If you give risperidone, it stops for some time, but your OCD is lifelong thing. You cannot keep on giving risperidone lifelong. You have to train the child to live with it. So we did that and she became okay. She got married. Unfortunately, there was a little problem after marriage. Suddenly she again started having, but then also we didn't give the drug. We only told her, keep the drug with you. If you think you can't manage it, you think, but it's a challenge. I can manage it. I can manage it. She never took the drug, but every time in her bag, the drug will be there. That is only to give a confidence that if I am alone in the room in a different place, then you have. That is the second thing. The third thing, I actually, when we started the program, there was a phone call. I know you saw that I was attending a phone call. It is actually a patient I referred yesterday to Paul Russell to Vellore. Okay, I want to make sure, have they gone there or not? Yes, they have already reached. They went by flight because tickets were not there. Now, what is the case? 17-year-old girl who had been seen by 5 psychiatrists and having minimum 3 medication. Each one is giving 3 medication. Very pretty girl, very sweet girl, very nice girl, came with a mother and father. Both are not, they're very normal people, not over religious, not over this thing, or bullying type and all that. But she had problem with the mother because mother is not understanding like. Okay, what was the problem? She had classical picture of depression. But along with it, she also had hallucination and some sort of delusion. I can't say it is delusion, but something to do with that. Okay? And all this medication has not worked. Then I said, now there is no point in showing my psychiatrist and starting another 2 drugs. I said, you go there, just have a look, let him have a look at it. And we are having holidays at end of next month. 2 weeks children get holidays. Book the room for there to stay there for 2 weeks. She'll be all right. Why I'm saying this is because same sort of presentations we had, where everything cannot be done in an OP basis. You may have to admit the child by a child psychiatrist, not an ordinary psychiatrist. But unfortunately, we don't have many centers like the Vellore is, lucky. Bangalore is lucky. Now, maybe even Kozhikode, Calicut is lucky. But most places don't have another. Trivandrum also, we have a child psychiatrist now. So his OP is, how many, 40, 50 and all in one day. Because so much of demand is there. Second, one more point, and that is on anxiety. Anxiety, madam, both of you gave very good talk. Anxiety, you just skipped little bit that DSM 4-5 type of anxiety. You could have said little more on that, because panic attack is entirely different. Panic attack is something, unless you see one, you can't understand this is panic attack. The person is sitting there quiet, having all the problem, build up, go to the roof and then come down. In between, it will be diagnosed as heart problem, and most of them may get a, ECG long ago. Now, of course, you will get a, echo done. Nothing wrong in that. Sometimes you may have to do that. That is one thing. Separation anxiety is there for smaller children. You have, other sort of social anxiety for the children. And it's systematic desensitization can be used in many of these, but really it is the most effective for situation called phobia. Okay? And phobia is something that we need to understand. Phobia is not too much of fear. It is actually autonomic symptoms that comes along with it. Child is not fear alone. More than fear, it is the autonomic symptom that destroys the child. And this is even important. The girl yesterday said she also had post-traumatic stress syndrome, because her closest friend, elder to her, this girl is 17, other one is 24. In the COVID time, they became so friends. The moment they said so friends, I had a lingering feeling whether it was related to something sexual, lesbian and all. But as a 17-year-old child, I didn't want to ask unnecessarily, so I kept quiet. But then I realized they were both interested in films. Whole time they were trying to do small short films and all that. Suddenly she died of COVID. This girl could not take, and she showed all sort of symptoms which the parents could not understand. They thought it's an adolescent bad girl creating nakra, like that. So she never got treated at that time, PTSD time. And usually what we say, you can cry for 1 week, 1 month, 3 months, but even 1 year. But if you are crying after that also, it is not affection for the person died. It is actually illness. It has to be treated. Okay. So this child also had, I didn't want to say the whole thing, but this child also, the whole starting was that we do not know whether everything started with PTSD already she was going for depression, and this, this incident precipitated. We don't know that. That probably they will work up in Vellore for a long time. They'll be staying there for a few days and then work up. Okay. Thank you.
Thank you very much, sir. Sure, ma'am, please.
Okay. Thank you, Dr. Nilay sir, Dr. Amitha ma'am, and Dr. Shubhada ma'am for sharing your expertise, and special thanks to Dr. Nilay for sharing the screen as well, and save our time.
Thanks taken.
And I would like to request Dr. Kavita ma'am to take some feedbacks from the seniors and have a vote of thanks.
Thank you, Shilpa. Thank you. I'm thankful to each and everyone who are present here. So first, I would like to take the feedbacks. Respected Geeta Patil madam is there. Ma'am, may I have your feedback, please?
Thank you very much. I think both the presentations were really excellent. Maybe time is very short to discuss everything, but MKC sir has already elaborated certain points.
Everything,
Sir,
yes.
everybody is asking for TSQM screening questionnaire. Maybe it is available also, but sir can, if possible, sir will
Sir,
share.
please do share this on
I can
WhatsApp.
share. I can share.
Share, sir.
So that is really helpful in a practice. Even if it is a busy practice, it is possible.
Can you send me a mail? I am forgetful always. Send me a mail tomorrow. My PA will send to you. Okay, don't worry.
Sure, sir. I'll send you some mail. Reminder mail, sir.
And all the points were very well covered, and that privacy, confidentiality already, that substance abuse is always issue for many people to discuss. So mild, just one or two smoking not to be included in a privacy and confidentiality. So that was cleared doubt, and drugs and these things will be taken care later. And it's an excellent thing. And both all Kavita, Dr. Shilpa, Avinash, and now everyone has Dr. Shubhada and Dr. Amitha have presented very well, and Dr. Preeti and MKC sir has presented all the doubts. I need not have to give my feedback. So thank you. Pranam, Dr. Pukraj sir, Pukraj Bapna sir. So many are there. You can ask. There are many who have seen many cases. And what sir told is that OCD is the most difficult thing to treat. I have got one girl who washes her hands, feet repeatedly, and she's very brilliant girl. Though I have sent her to Nimans and this thing, it's not, as sir has told, that not only medications, but we have to make her to understand certain thing slowly, gradually, but again it happens, and it's a very difficult thing to be treated just like that. Thank you very much.
One other small thing. We were talking about CBT and REBT. Both are cousins. Both delay on same thing. The only difference is in REBT, you do much more on the emotional part. In CBT, much more on cognitive part. I forgot to say, actually, our Nasik friend has told me to emphasize the need for thyroid screening in many of the depression, so-called depression. Kanika just called me because he can't, his mobile has some problem, so he couldn't say it. So I think thyroid screening. Okay, sir. Pukraj, sir.
Thank you so much.
Welcome, sir. Welcome.
I was a patient listener, and it was really excellent to hear all of the participants as well as the speakers. This is the need-based and problem-oriented program. I must congratulate Kavita and Shilpa for the webinars they are doing very, very excellently, and I'm sure, and I'm really proud of this team. They're doing very well. Congratulations again.
Thank you, sir.
Moreover, if there is blessing of MKC, so the program has to be wonderful.
Thank you, sir. Thank you. I'm really thankful for this to Dr. MKC, sir. Dr.
Should I say Pukraj sir was my first student.
She will not
25 years ago.
Yeah. I'm still your student.
First student.
I'm still your student.
First batch student 25 years ago. Okay.
Sir, MKC, sir, I would like to ask you one question. As you said, when the patient come to us for any other issue, whether routine or vaccination, and we have to just ask few questions. I find some issue is there. The child doesn't seems to be okay. Should I call back the patient for the counseling?
Yeah, I think so. I think so. If you don't attend. Now, if you listen, if you are in a teaching hospital, you can ask your assistant to do a workup. If you are in a private clinic where you are alone, you can't, so many patients are waiting, you can't do that. Then give a time when you are probably little more free. That's all.
Okay, sir. Okay. Thank you, sir. Thank you.
Can I add
Hima
on?
Bindu ma'am has joined, I suppose, sir.
Dr.
Hima Bindu?
Vima Bindu, madam, I don't know, but she's not there. Whether, sir,
No, ma'am, she sent me a message that she has joined.
thyroid screening plus anemia screening, both are very important for depression and anxiety. So Hima Bindu, madam, I think whether she's there, we'll check it. But she was not in the country.
I got a message that she has joined. Further, sir, is there.
Hima Bindu is having holidays in US, I think.
She's enjoying.
Sir, family tragedy, she has gone there. Family tragedy.
Oh.
MKC.
Hello. Hello.
Yeah, Dr. Pardal sir is there.
Yeah. Kavita, congratulations.
Ji,
I am joining from New York.
Ji, sir.
I have joined from New York.
Okay, sir. Please.
Yeah.
Oh, very
Thank
good.
you for joining from there, sir. Thank you, sir. Thank you.
Yeah. I congratulate to you and your team and all the speakers. They have covered the topic very well. So thank you very much. My regards to Dr. MKC Nair. Myself and Dr. Pukhraj Bafna went to Trivandrum for his first conference there 25 years back.
Yes.
So, yes, if Dr. Pukhraj Bafna remember, we were there. And our meeting with the Dr. MKC Nair was wonderful. So my sincere regards to him. Thank you.
Thank you, sir. Thank you. Dr. Ashwini Agarwal, sir, is also there. May I request Dr. Ashwini Agarwal, sir? Dr. Ashok Mehta, sir, may I request to say a few words?
It was a very excellent session, and we do come across so many problems, and this is a very good platform to sensitize the pediatricians who are not into adolescent practice, because the problem which we are discussing over here are all a day-to-day problem, and many parents are discussing these things with us. But now with the insights of these ongoing sessions, we are more kind of prepared to either take them or refer them appropriately and in time to get them the right treatment and help for their mental well-being. So congratulations to Kavita and the team for an excellent webinar series going on. Wish you best of luck.
Thank you, sir. Thank you. I request Dr. A.T. Dapke, sir. Dapke, sir, kindly unmute yourself.
Okay. Am I audible?
Yes, sir.
After listening to such a learned galaxy of persons, especially the speakers, and we have luckily our country's best psychiatrist, and so it's very difficult for me to add something, but what my worries were, whatever cases we have discussed or presented, they represent, I think, upper or middle class families. And my worry is we have a huge population with parents who are uneducated, parents who are having problems in family, parents of the two parents, there is separation, restriction, and third thing, our teachers, especially the primary and middle class teachers, are not exposed to pick up early abnormal behavior. And this ends up in a problem which at the stage adolescent, pre-adolescent level, they become to some extent, even after treatment, the problems persist to some time. So this learned group, I would request one thing. First is our middle and primary school teachers, what is should be their simple questionnaire or criteria so that they can pick up, oh, this child requires extension, which may be offered them at the correct place. Our parents with family problems, separated families, father especially addicted to so many drugs and so many things. Now, in this situation, what are the solutions which can offer in a country where 140 crore people are there and huge population is having still many problems which probably, if picked up early, the problem severity may reduce to some. So I would request our learned group today to find out a simple interventions which should not have some help to the children. Thank you very much. Once again, I am grateful to all of you for consulting.
Sir, can I just answer a few of your
Yes,
queries,
yes.
sir?
Yes.
Sir, at Adolescent Health Care, have a teachers training module which was led by Dr. Shubhada and her team in 2019, and it is online, accessible, and any teacher can access it. So we will put this link on the group, and I would request everybody to share it with the teachers who are there. And the second question about training them with a, simple kind of a, so whenever we go out to the teachers, we talk to them, we often talk to them about head screening tool. And I myself have shared, it's a very easy tool to do to get a good history about the psychosocial history. Your third question about alcohol, it's quite common. And like, as a pediatrician, sometimes we have to go beyond what we are trained to do. But I would say keep in touch with the social service schemes of the government of India. Nowadays, again, there is a lot of online de-addiction programs, including tobacco cessation and alcohol use. So I think we should keep updated with that. There are a lot of helplines also available, which can be easily told to the patients, and keep in touch with the government hospitals, which is there, referring them accordingly to the psychiatrist and to the social service schemes. So I think as a pediatrician who's even working in private practice, we should be aware about what is available in our country. And once we go into it, we'll realize that there are actually a lot of schemes available. So this is just
very
my
nice, very nice.
Yes.
Thank you very
Yes,
much. Thank you.
Thank you, sir. Thank you, ma'am. I think it's now time to conclude. So I, Dr. Kavita Menghani, on behalf of CGAHA, would like to thank each and everyone present here. You all are really making this series really successful. I pay my gratitude to our special guest of today's program, Dr. Prakash Veer Arya, sir. Your presence and blessings means a lot to us. I'm thankful from the bottom of my heart to our eminent speakers, Dr. Amitha ma'am and Dr. Shubhada ma'am, especially that role play. Your talks were really enlightening, and I'm sure it was really helpful for all the audience also. The discussion was today especially very good, I suppose, because the talks were finished timely, and we had a good discussion today. So I'm thankful to both of you. Thanks a lot. And I'm thankful to Dr. Nile because on an emergency basis, Dr. Prankur couldn't join. So you took over both the sessions and you do it very nicely, very smoothly. Thanks a lot for conducting this very smoothly. Thanks a lot to all the respected office bearers of CIAP, CAHA, and CGIAP on or off the dia for your kind support always. My gratitude to respected Geeta Patil Madam, Dr. MKC Nair sir, and Dr. Preeti Galagali Madam for guiding me throughout. For this program could have not been successful without you, sir. So I'm really thankful to all of you. And my special thanks to the respected Daki sir, respected Bafna sir, respected Amar Singh Thakur sir, Madhushri Madam, each and everyone present here. My special thanks to my CGAHA team for working all hard work, and very special thanks to the technical team sent to At the last moment, 11th hour, they just took over. Zuventus had some technical issues. So I'm really thankful to the Santur team for all the successful program. And thanks each and everyone. So this program was really nice. Thank you, speakers. Your talks were really wonderful. And this discussion was even more so wonderful. So thank you, MKC sir. You are really wonderful. I'm really big fan of you. I have no words to express. Really big fan of you. Thank you, sir. Thank you each and everyone for wonderful session.
Thank you, ma'am. And finally, a big thank you to all the participants for your active involvement. We hope you found this session valuable and enriching. And we look forward to seeing you at our next session. And that's have a great evening for today.
Have a great Sunday.
Yes.
Especially so much of gathering come on Sunday. So I am really thankful to each and everyone. You all spend your valuable time with us on Sundays. So that's really great. I think Shalini madam was also there. Shalini madam, thank you. Thanks a lot.
Welcome. You're doing so well. And I mean, like, I think we are just waiting for this Sunday to come and hear you. And what Dr. Preeti said just now, she enumerated few of the upcoming talks. That makes it even more interesting, you know.
Yeah, ma'am, all the talks are and we beginners are really learning a lot from this.
Yes, even we, I mean, we all are.
We all are learning from.
Kavita, this was all because of your smiling invitation and smart gesture of MKC and all the time smiling Preeti और शिल्पा तो बिल्कुल बाग न जाने क्या कहें और हमारे मैडम नागपुर वाली वो तो कई बार आ चुके हैं छत्तीसगढ़ में we should invite her again and let ये बयान जारी रहे, let this continue.
Actually इस प्रोग्राम ने ना हमको जो है सबको तहे दिल से शुक्रिया क्योंकि सबके बहुत सारे अच्छे मुझे कॉम्प्लीमेंट्स मिलते हैं और फोन से आते प्रोग्राम के बाद तो everybody is actually gaining a lot. So whosoever सारा का सारा टीम जो ज्वाइन है से जुड़ा हुआ है, I'm really grateful to all of you, all the speakers, MKC sir, Geeta madam, Preeti ma'am, everyone. Really, thank you.
Send the list of coming programs to everybody. Because initially they would not have listened to it. After hearing one or two, now they will get interested. Just tell them what are the incoming programs. Okay.
So they'll all get addicted to it.
Yeah, sir. Everybody keep waiting. मेरे पास messages आते हैं. कभी-कभी तो लोग जिस दिन नहीं होता उस दिन join कर लेते हैं.
That is the bottom line.
Keep on asking for the link. So that's the beauty of this program. Thank you, everyone.
Thank you.
Thank you.
Enjoy.
Everyone can
छोड़ने का मन नहीं कर रहा है. बंद करो ना. छोड़ने का मन नहीं कर रहा है.
जी सर.
जी सर. Goodbye.